Really energetic considering you took a AFT this morning, right? That's great. That's sarcasm, by the way. So, for those of you who don't know me, my name is Lieutenant Colonel Gutierrez. I will be teaching you ID and MPH. MPH is more geared towards military stuff, not necessarily public health per se. As we go through ID, we will be talking a little bit more about public health as well, okay? Because those two really go intertwined. Now, before I joined the Army, graduated college, and I was about to start an illustrious singing career. If you can tell by my voice, right? A little loud. I tried out for, can you guys hear me now? No, yes, maybe? Yeah. All right, I tried out for the Backstreet Boys. Okay, got beat out by Justin Timberlake. It's okay. But in all reality, what really ruined my singing career was puberty. All right. Aside, after I joined the Army, I got a tonsillectomy. Tonsillectomy nicked one of my vocal cords, so I have vocal cord dysfunction. All right. So sometimes as we go through this, my voice will go up and down. Please let me know if you can't hear me, and I will adjust. Okay? Questions? No? Yes, maybe? I am a product of IPAP, so even dumb kids can make it, right? So that's me. I'm your poster, right? I've had a pretty good career in the military. For those of you in the Army, if you want to talk about the future of PAs in the Army, please let me know, okay? I am in the know. I have made certain things for future PAs, I have made certain things for future LISCO stuff. I have held some pretty decent positions where some PAs in the military have not. So if you want to know about some future things for the Army, please let me know. Navy guys, I engaged with Commander Long, Captain Long. So you guys are starting to emulate a little bit more of what the Army is doing. So if you guys want to talk a little bit, we can do that too. Air Force, and you guys are going to be in for a world of hurt, because you guys are starting to look like us a little bit. That's what you're going towards in the future. So you guys will possibly no longer just work in family medicine clinic. You guys may be going forward just like the Army PAs, okay? And then practice real medicine. Okay? All right. When I came through, I was a single parent. Thank goodness for my sister. She helped me take care of my daughter. Daughter's all grown up and out the house, right? So I understand, as do most of the other instructors here, understand what you guys are going through, all right? Don't think that we don't know what you guys are going through, because we do. All right, so please do not think that we don't understand what's up. If you guys do have any issues, please let us know. Let us know before the issue blows up, okay? Because after it blows up, it might be a little bit difficult to manage. But before it blows up, you know, we have a chance to try to take care of it and help you as much as we possibly can, all right? And that's one of the things that we're here to do, particularly myself as a deputy for the Army guys. We are here to try to help you as best we can, all right? We want to see you guys succeed in the program for selfish reasons, right? Because I am a fat old guy, and you guys will eventually have to take care of me, right? So I want you guys to be the smartest you guys can possibly be, all right? Now, before we start, you may have heard that this is a little difficult. Yes, no, maybe? Probably. There's stuff out there, got it. What I need you to understand is, some of the test questions that you're gonna see are written in a pants style when they're written by me. I've done a 1-year NCCPA fellowship where I've written pants questions. So when I try to write some of your questions, they are pants style type questions. So they're a little bit different than what you're used to seeing in some of the other classes. And as you move forward, some of the other instructors will be doing the same thing during the semester. This semester is your heaviest semester, all right? The other aspects to this is that these questions are gonna be secondary and tertiary type questions. What does that mean? That means that the expectation is that you know the disease process that I'm asking about without me telling you, and then I'm gonna ask you about a lab, or I'm gonna ask you about an antibiotic, or I'm gonna ask you about a radiologic issue, okay? So, we think it's a little bit difficult because this is the first time you guys are doing some of these type questions, okay? And it's gonna be one of your first classes. All right? So it may seem a little bit difficult. But what I will tell you is, as we go through this, I'll try to hone in a little bit more on the things that I think are somewhat important when you're moving forward with either actual patient care or the PANS overall. All right, and I'll point some of those things out. And as we go through, I'll also let you know some information that, hey, this is not gonna be on the test. So, you know, you're more than welcome to strike through those PowerPoint slides so that you don't have to worry about it when you're studying, right? Does that help? Yes? All right. So part of that, there's also a lot of stats. There's a lot of stats in these slides, okay? The stats are to demonstrate to you that this stuff is still happening around the world, not just here, okay? Because it still happens in the United States, even though it's an infectious disease thing, and we think we're pretty much healthier than everybody else in the world. We can tell by our weight, right? Because we're one of the fattest countries in the world now, right? But it still happens here in the U.S., okay? So geography is gonna be one of those things that you may wanna make sure you brush up a little bit on, or when you see those things on the slide decks, kinda remember, okay? One of the reasons why I say that is because location is extremely important for infectious disease. Location is extremely important for infectious disease. Right? Some of the clues that I'll give you in some of the questions that I'll put out will have like, hey, this person was in Southeast Asia, or in Africa, or in Southwest US, or in New Mexico, where most of the plague cases happen in the US. All right? The other piece to that is, wherever you see most commons, try to remember the most commons. Most commons are gonna be one of those big things that the PANS is gonna start asking you questions on. All right? Because this is the very first test that you're gonna have, national test for certification. And a lot of it is based on most common stuff that you'll see. All right, anybody have any questions before we start? Yes, no, maybe? Anything? Why sky blue? Fraction from the light? All right. So the first thing we're gonna cover is fever of unknown origin. This seems like a very simple topic, but it ends up becoming very, very difficult. For here, we're just gonna cover the definitions, some of the things that you should do, and then when you get to peds in your senior semester, you guys will go through an entire fever of unknown origin case in a pediatrics case, all right? As with everything, you have to have a definition. This is the way it is, right? And here's your definition. Fever of unknown origin is a condition where a patient has prolonged fever without an identifiable cause despite extensive evaluation. Key point, right? Key point. Identifiable cause, extensive evaluation. That means somebody actually went and did some exams on them and tried to figure out what was going on, right? So they've done a bunch of exams, they just can't figure out what's going on. Okay? And the important part of that is, without knowing what's going on, right? How do you develop a plan? You're the doc, right? I show up to your office, you've seen me for a minimum of 3 times, I have a low-grade fever, we've done a whole bunch of tests. What do you tell me? What do you tell me? How do how do you tell me that, hey, we've done a whole bunch of tests and we still can't figure out what's going on with you? I realize that you have a fever and something's wrong with you, but I just don't know what it is. Right? So things to remember, things to keep in mind. And I say that because as we go through ID, I'd like you to understand that some of these patients are frustrated. Right? Sometimes they end up in ID because primary care or a specialty can't figure out what's going on with these patients. So they end up in ID's doorstep. And then we do a really good history and physical. That's key for ID, to figure out what's actually going on. So sometimes these patients are already frustrated. So just be careful with them, all right? The other aspect to this is, don't think of, you guys know what zebras are? When we talk about disease processes, zebras are something that is very rare, right? Pheochromocytoma, very rare, right? But it can almost be anything. So don't think of the rare things. Think of the more common things, okay? With fever of unknown origin, it's usually atypical symptoms for a common diagnosis. Atypical symptoms for a common diagnosis. That's usually part of the presentation for fever of unknown origin, right? So it's not something that's way out there in left field, but it could be something presenting, it's just not presenting like we normally are used to seeing it present. Right? So most common stuff. We break these out into 4 distinct categories. Classic, healthcare associated, for those of you who have been practicing medicine for a little bit, healthcare associated, also be considered nosocomial. Okay? You guys remember what that word is? Something that happens inside the hospital. Right? Immunodeficient, and then HIV related. Now within each one of these categories, we have definitions for each. Okay? So, classic, this is generally the most common one, right? Here's your fever, 100.9. Okay, that's the minimum. Quoted on multiple occasions. Okay, what in the world's multiple occasions? 3 outpatient visits, or after 3 days in the hospital, evaluation with no identifiable cause. Okay. Duration of fever for at least 3 weeks. No clear etiology despite investigation. Okay, so there's a key point. We've looked at stuff, we just can't find it, figure it out. Right? Look at the times. The times are 3 outpatient visits or 3 days. The number 3 is there for all of them when we look for definitions. All right? The next one would be healthcare associated or nosocomial. All right? The specific point with this one is that when they get put into the hospital, when they get admitted, they do not have a fever. The fever starts after they get admitted to the hospital. Okay? That's your key point for differentiation. Okay? The fever occurs after they get admitted, not before they get admitted. Okay? And just like the other ones, 3 days of appropriate evaluation, that cause remains uncertain. Clear as mud so far? Yes? All right. The big one with healthcare associated are, you have to remember how many things, depending upon what's wrong with you, get put into you, right? You get an IV, you get a cath, you get a urinary cath, you get a whole bunch of stuff stuck into you, right? So there's a bunch of possible reasons that can cause you fever of unknown origin after they've admitted you, all right? And remember, the key to this is figuring out what the cause is. Because once you figure out what the cause is, then you can set up a plan and take care of it. All right? So your next 2, immunodeficient or neutropenic. The standard for neutropenia, the standard range is anywhere between 2,500 and 7,000. Right? So the magic number for neutropenia here is less than 500. All right? And neutropenia could be caused by a whole bunch of different things, like cancer, chemo, not HIV, okay? Because if you look at the next one, the specifics of the next one is that he or she must be HIV positive. All right, so we have 2 difference, and the differentiation being neutropenic, okay? less than 500 white blood cell count. And then the next one being positive for HIV. Okay? The one for positive HIV is a little bit different because it gives you fever of 4-week duration. It's the only one that's different in that manner. And the reason why you get that extended is because you already have a decrease in your immune system, so we already know that your body is going to have a harder time fighting. All right? If you remember any numbers, remember CD4 count less than 200. The CD4 count less than 200 is when you go from HIV to AIDS. Okay? We will be talking about HIV later, but just to differentiate that within this. Okay? For fever of unknown origin, just like infectious disease overall, a good history and physical is gonna lead you to a possible answer. I'm sure when you were doing medical history, you guys were like, why do I need to ask all these questions? And do I need to ask all these questions every single time? No, you don't need to ask all these questions every single time, but you need to tailor the questions you're asking to the reason why you're asking them. Okay? So here's a giant list of stuff, right, that cover your marginal information and or your history and physical, your HPI, and or review of systems questions that you can ask when you have someone with fever of unknown origin, right? Family history. Why? Because autoimmune issues can cause fever of unknown origin. But you won't know that unless you ask. Right? Your immunization status, your occupational history, right? When you're doing your junior clin course stuff, right? One of the questions that you should ask should be, hey, what do you do? What's your job? Okay? And that should be asked for multiple reasons. In this case right now, we're asking because we need to know what kind of job they do, right? One of these jobs is prison worker. We already know medically, statistically, that prison workers have a higher propensity of getting tuberculosis, right? Tuberculosis can actually cause fever of unknown origin until later on where we start having chest pains, difficulty breathing, coughing, and all the other things, right? But asking all the appropriate questions during your HPI will get you to that point. Understand that we have to be a lot more detailed when we're doing infectious disease stuff. I like this slide because it really tells you, look, infection is the most common cause of fever of unknown origin. Okay, period. The numbers statistically, when you look at them, 25 to 50% of infections may present as fever of unknown origin. And here's the thing. Sometimes we just give people antibiotics, they get better, and we just don't even know what the problem was. We just know that they got better. That's wonderful. But again, we don't know what the problem is, right? So sometimes that's the way it works. We'll just give somebody empirically antibiotics and they just get better, right? So the next one down would be malignancy, all right? And this is extremely important because if you catch malignancy soon, the earlier you catch it, the better off your outcomes are going to be. But you're not going to get to that point until you start asking all these questions. All right. And then we have miscellaneous, we have autoimmune, inflammatory, 10 to 20%. But then the last one, your undiagnosed fever of unknown origin, fall into that, hey, maybe I gave them some antibiotics and that person got better. The other one that falls under that category is behavioral health issues. Okay? There was a study I read where a lady was in the hospital for a fever of unknown origin. She was taking these herbal pills. She knew she was taking these pills that caused her the problem, but what she wanted was the attention to stay in the hospital. So eventually the providers figured out that, hey, she had a secret stash of pills in her room. But again, we can't discount factitious issues causing some of this fever viral origin. All right? Here's a whole bunch of things that can cause it. All right? TB, gallbladder disease, HIV, vasculitis, UTI. Hey, it could be a myriad of things. Okay? When you ask the questions, when you do your HPI, when you do your physical exam, all this stuff will kind of sort of lead you down a little path that'll try to get you set up for a plan to try to take care of your patient. All right? But always remember the most common things first. Now, how many National Guard and Reservists do I have in here? Okay, so a couple of you guys. I bring this up and we talk about it throughout ID, okay? The socioeconomic ramifications of what you do. What does that mean? I don't even understand what those words say. What you just said, I don't understand them either. But, nevertheless, whatever you order is gonna cost somebody money, right? When people come see you, they may or may not have insurance, right? How does it get paid? How much is their copayment? Does their insurance actually cover what you're asking them to do? And that's gonna be based on the note you write and the questions you ask, okay? So there's a lot of other ramifications that occur with what your thought process is, especially once you start working in the civilian sector. Okay? In the military, not too much of an issue. They'll pretty much try to get you whatever you need. Okay? System from that aspect is great. Okay? But once you start working in the civilian sector, it's a lot different. Right? I was moonlighting at Baptist Homestead Hospital when I first started working as a civilian, taking care of patients, right? Hey, this is what I always prescribe for you. Here you go. They go to the pharmacy calls back. Pharmacy can't talk to the nurse or the administrative management people. They have to talk to you, because you're the one that prescribed it. Hey, this person's insurance doesn't cover this medication. Hey, but I wrote generic. Okay, this person doesn't cover this medicine and or the generic portion of that medicine. You need to pick another one. What do you mean I need to pick another one? That's what they told me, right? So you need to understand some of the things that your decisions make, especially when you're in the civilian sector. All right? There are other things that can affect. So the most common things are cheaper and easier to attack and the more difficult ones. So if you start going down the easier ones first, which usually should pan out most of the time when you're looking for something, you should hopefully be able to save that person some money in the civilian sector. Okay? So what are we going to try to do to figure some of this stuff out? All right, some of the things that we're going to try to figure out, right, we'll do blood cultures. Here we want 3. They usually should be at least 30 minutes to an hour apart when you're doing these blood cultures, right? Because you want to see if there's any spikes or anything going on. And then you'd like to try to take them from different parts of the body, preferably. Okay? If you can't do 3, you need at least a minimum of 2. All right? Blood cultures are a little bit difficult, depending upon what it is that you're looking for or what it may be. Do we got any lab techs in here? One. How many different types of mediums are there to grow cultures in? There's several. There's a lot. Okay, there's a lot of cultures. Mediums, right? So I'm gonna send this off to the lab, they're gonna put it into a little culture plate. The medium sometimes is what determines its growth. The temperature determines its growth. And the type of infection that it is will determine its growth. Okay? Some of which has to be a specific type of medium in a specific type of temperature, right? Not standard agar in the standard culture box. Right? So sometimes you'll get a good positive result, sometimes you won't. Stuff grows slowly, depending upon the infection that we're talking about, and go a little bit slower than others, right? So do you really want to wait 2 weeks before you actually start treating somebody? The sooner you start treating, the better the outcome's going to be, right? So just keep those things in mind. We would also do acute and convalescent cultures, or really just blood draws, right? We want to know what it looks like at the beginning, when somebody just shows up, and then 2 to 4 weeks later, we want to see what it looks like then, okay? We would be looking for IgG and IgM. You guys remember what those are? We'll be talking about a lot about those as we go through, right? IgM, something that pops up initially, right? So as soon as you get sick, your IgM pops up, right? As you get better, as your body realizes how to defend itself for the future specifically, it'll develop into IgG, right? So if I draw something because you just showed up today, I should really not see much IgG, right? I should see a whole bunch of IgM. And then as it goes on, you'll start seeing and developing the IgG. So now you'll have more IgG. That means that the person has already developed through some of that disease process. That's what those acute and convalescent titers are for, or blood cultures. Then you have the standard culture, right? When we talk about nosocomial or health-related type stuff, all these things that get put into your body, right? You can take those and you can culture those tips that get put into your body and send those off, right? They have to change out those IVs every, say 48, 72 hours so that they don't get infected. But those things you can culture and send off, right? Your CBC, you have your neutrophils, right? Your white blood cells should be up if you have some sort of infection, right? Your lymphocytes will be up if it's more related to viral issues. And then your eosinophils will be up if it's parasitic or allergic issues, all right? And then you have your ALT, or your LFTs, ALT and AST. Way that I remember, ALT, L, right, is specific for the liver. That one really deals with a lot of liver muscle. AST deals with liver plus heart, tissue, skin, skeletal stuff. So AST deals with the liver and everything else. ALT generally just deals more so with the liver. And we start looking at which one goes up and down. Right, you have LDH. Right. Typically varies depending on the lab that you send it off to. Right. Usually you'll see elevation of LDH in malignancy. Okay. And when you talk about that one, or you combine it with ESR, which is the one on the bottom. ESR is more of an inflammatory marker. When you combine it with LDH, then you can start looking for more specifics like CA-125, which is specific for ovarian cancer, or AFP, which is specific for liver carcinoma. Okay. So some of these labs are going to help you kind of direct you in a path that may get you an answer so that you can set up a plan. Okay. Your CMP. All right, so real quick, you guys remember your Clin Lab stuff? Sure, okay. I'm glad you're positive about your stuff. All right, so a lot of questions that I usually ask my junior clinical group, right? What kind of labs do you want? Sometimes they say BMP, sometimes they say CMP, and I go, okay, what's the difference? Like, I don't know. Like, all right, great, then why are you ordering? Right? This goes back to the socioeconomic reason, right? You're having them order CMP versus BMP. A CMP has 18 different labs in it, a BMP has 8. BMP covers your kidney and electrolytes and glucose. Your CMP covers all of that, plus your liver enzymes, and your albumin, and your protein. So, know the differences, okay? So you can kind of figure out why you need it and which ones you need to order based on what you're thinking or what your thought process could possibly be for whatever you think this person may or may not have. Right? Now, if you're working in the emergency room, by all means, knock yourself out, bam, rainbow. I want to order everything in the lab. Right? We don't generally like to do that, especially if you're primary care. Okay? No need for that. All right, everybody, lottie-dottie, will give chest x-ray. Everybody. Okay, period. After that chest x-ray, if it's not pneumonia, bronchitis, or something that you can take care of with some antibiotics in the lungs, then you can go and move on to something else. All right, there's some other imaging things that you can go to, upper lower GI, you can do abdominal CT, you can do MRI if you have neurologic symptoms. Please do an MRI if you have neurologic symptoms. You may also want to do a lumbar puncture. All right. And then that echo TE and that echo TTE, the transesophageal echocardiogram, that is an invasive procedure. You need to knock somebody out. You will put it down their throat, down to the middle of their esophagus, and start doing ultrasound stuff to see how everything looks, particularly in the heart. Right? So be careful when you start picking some of these things, because not only do they cost money, but they're invasive versus the TTE, which is not invasive. Okay? So lots of different options. Ultimately, if you do see stuff that's different on the individual, biopsy and send it off. Okay? Biopsy and send it off. Okay? You just mentioned the lumbar puncture. Hey, if you have neurologic symptoms, do a lumbar puncture. Okay? CSF is cerebrospinal fluid. Okay? You get that from doing a lumbar puncture, LP. Okay? If you have some swollen lymph nodes, hey, aspirate them, send them off to the lab. Biopsy, send them off to the lab. A lot of ID stuff. Okay? And we'll talk about the plague. The plague gets into your macrophages. Macrophages like to go back to home. Where's home? Home is the lymph tissue. Right? Lymph tissue is very vascular because it goes to the rest of your body. Once it makes it there, then it can spread to the rest of your body. Okay? That includes your cerebrospinal or your brain. Okay? Skin, bone marrow afterwards. That one hurts. You may want to knock somebody out for that. That hurts quite a bit. But again, if that's what your thought process is, then don't forgo it. Make sure that it happens. All right. So management, hey, make sure you stop all meds for at least 72 hours. Some people won't even realize that they just started a new medication, or they started a new multivitamin that they just got off the web. That comes from God only knows where, right? That's made up of God only knows what, right? And they think it's helping. Maybe the culprit, okay? Try not to use antipyretics initially, because you need to figure out what is causing the problem, right? Corticosteroids, no. Corticosteroids mask the problems. If you mask the problem, you're not gonna figure out what the problem is. If you don't figure out what the problem is, you're not going to be able to develop a plan. Okay? And then, as we mentioned earlier, sometimes we just give people antibiotics empirically, and they kind of sort of get better. Sometimes, if we do this, it can block some of the process, and we think they get better, or we don't complete the antibiotic, and we start causing some resistance. So we don't want to necessarily do that until we kind of figure out what's actually going on. Okay? Don't necessarily forget about the behavioral health aspect of this stuff. Okay? Maybe a small aspect, but sometimes it's a big one. Okay? But the key to all of this is basically treat the underlying problem. All right? So when you get to peds, you'll go through an entire case. This gives you the definition, this gives you some of the things to look at while you're working through patients. All right? Anybody have any questions about what we just covered? Yes, no, maybe? All right. You guys want to take a 5-minute break? 10-minute break? Yes? No, maybe? All right, let's start off with biological warfare. Okay, these are what we're going to cover. These are basically all category things. Anthrax, plague, smallpox, monkeypox has been changed to mpox. That was changed back in 2023. So here's your definition. The intentional use of viruses, bacteria, fungi, or toxins derived from living organisms to produce death and disease in human, animals, for plants. So here's the thing. There's about 195 countries worldwide, more or less, depending upon what you consider a country is, right? About 180 of those countries have signed a 1975 Biological Weapons Convention prohibiting the development, production, acquisition, and stockpiling of any of this stuff. 180 countries signed that. Do you think 180 countries did that? All right, we gotta be honest. Not to say they didn't do it either, right? We gotta stockpile of anthrax, we gotta stockpile smallpox. Hey, why? Because our justification, we use it as research. Okay? For those of you guys who like research, that's our justification. Okay? But we have them. I say that because I'm sure everyone else has them too. Right? So it is a possible threat for us. These are category A, B, C from the CDC. Okay. The three that we're really going to cover will be anthrax, plague, and smallpox. Those all fall in category A. And later on, we'll be doing some of the category B and C's. Okay. The big issues with the category A's, excuse me, are the high priority. Okay, agents are considered to be top priority for public health issues. And you can see a couple of things that are on there. Easily transmissible, high mortality rates, major public health impacts, cause panic or social disruption, and require special action for public health preparedness. So if you look at most cities usually have a public health preparedness plan for some of this. If some of you guys decide to go into disaster management as a DMSC, this will be some of the things that you guys actually talk about. With the disaster management. You guys will be developing some plans on, hey, if somebody releases anthrax in the freaking subway system like they did in New York back in the 80s, what do we do, right? So that's the importance of the category A's, which are the three that we're really going to cover today, right? So the biological weapons are generally considered a poor man's nuclear bomb, right? So here you can see the cost for each one of these things, right? So conventional weapons, 2,000 per square kilometer, nuclear 800, nerve agent 600. For biological weapons, $1 per square meter. I can go online, find a recipe, how to do some of these things, and then just aerosolize it. Aerosolization is easy. It's as easy as turning that fan on right there and then just putting dust behind it and blowing it all over. Okay? That's how simple some of this stuff is. Right? So we have to be careful with some of these things. Okay, so the first one we're going to talk about is anthrax, Bacillus anthracis. My suggestion for you would be, hey, remember some of these big words, right? Because when the labs come back, it'll probably tell you have Bacillus anthracis in your lab. It's not going to tell you, hey, you have anthrax. Okay? So only the big words are what's on your stuff. How do you get it? Okay? So one of the clues for infectious disease overall, to include some of the questions that I'm going to ask you on your test, will be modes of transmission. That will be one of the clues that I give you for the most part. Okay? And here, when we talk about anthrax, contact with hides or infected animals, camels, cattle, antelopes, sheep, goats. That is one way that you can get it. Infected soil, another way. Ingestion of contaminated meat, another way. Right? So one of these things, inhalation of spores, another way. One of these things will be part of your clues in that test question. All right? Now, the Air Force has a great global health engagement team. So good that we, the Army, have modeled ours after theirs. Okay? Now, the Air Force global health engagement teams go out and interact with a whole bunch of folks in third world countries. And in third world countries, some of the things that are extremely valued are their animals, right? Cattle, camels, sheep, goats, right? That really puts them more so in harm's way than anyone else, right? So you, as a provider, need to understand what your soldiers, right, airmen, sailors, are gonna be doing so that you can kind of sort of help them ensure that they stay safe. All right? Distribution worldwide. There's a triangle southwest of San Antonio. A whole little area down there full of anthrax. No animals go down there anymore because I think 3 or 4 cattle died from eating some of the soil stuff down there because of anthrax. It'll be on one of the next slides. Infective aerosol dose, 8,000 to 50,000 spores. Okay, 8,000 spores is not much. It's a little bit. Okay. It remains viable in the soil for more than 40 years. Stuff doesn't die. Anthrax is a spore, so spores develop a hard outside protein shell that allow it to survive outside the human body. Once it gets inside the human body, then that spore shell sheds and then it starts propagating inside your macrophage. But those things can live outside of your body for greater than 40 years. Okay? Usually here in the US or in most developed countries, we usually don't have much of an issue with anthrax. Most of the animals are usually vaccinated for it, so it's not a big problem. But problems occur in the underdeveloped countries. And that's generally where the global health engagement teams end up going. Okay? All right, so this right here is not going to be on the test, right? But it demonstrates that this stuff is still going on, right? So here in 2022, 6 cows died 2 months period in San Angelo, Texas. So that triangle, if you're from this area, is the region of Uvalde, Ozuna, and Eagle Pass. There's a little triangle area there that soil is contaminated with anthrax. Okay. If you look at the letters that were mailed in 2001 containing anthrax spores, okay, it was mailed to several media offices and 2 US senators, okay. 5 people died from the inhalation of that anthrax. Is it extremely difficult to treat? It's not extremely difficult. But the problem is that we don't think about those kind of things, right? It's something that doesn't generally occur here, stateside, right? So it's not something that's gonna be on the top of your mind when we think, hey, these guys are having some respiratory issues. It's probably anthrax, without knowing the rest of the history. In this case, these guys received some letters and packages containing a bunch of white powder that got aerosolized, they inhaled, and then started having a respiratory problem. All right. And there you can see anthrax globally. In Malawi, 25 hippos died. Kenya, 3 people infected, ingested infected cow meat. Right, so this stuff is still happening worldwide. Okay, we have generally 3 types. You have the cutaneous, which is the most common. You have inhalation, and then you have intestinal. Okay. Simple cutaneous, right? Most of those folks work out in those type of areas where they have cracks or breaks in their skin, on their hands particularly, or their forearms. So when they come in contact with the infected hives, when they come in contact with the infected soil, right, it gets into any of those breaks of the skin. And that's how they end up with the cutaneous anthrax. Right? The inhalation spores get aerosolized from the soil where they are. Right? And then the intestinal can be the ingestion of the contaminated meat. Okay, cutaneous is the most common. Probably more than 95% of the cases you're in cutaneous of anthrax stateside. Now, there is another form called injection anthrax. Okay, relatively a new form. We're not necessarily counting it here, but just for your essay, especially if you're going to work in the civilian sector, particularly in an emergency department, it is a mix of heroin, injectable heroin, contaminated with Bacillus anthracis spores. And generally it's by accident, but nevertheless, that's what's been happening and that's what's been noticed in some of the bigger cities and emergency departments. Okay? So something for you to kind of keep in mind if you're gonna go work in the civilian sector. Alright? So cutaneous, alright, so it usually follows a little pattern. Alright? Most common way of contracting the disease is the cutaneous type, right? 95% of cases. Okay? Whatever break in the skin that you have when you contact whatever infected thing that you're contacting is how it's gonna get onto your skin. You get a little red bump, then you end up with a painless, small, raised bump or blister in the inoculation site. Key point here is that it's painless. Okay? Key point here is that it's painless. Once it swells up and it becomes erythematous and a papule or pustule, it ends up rupturing and it begins to ulcerate. At that point, it gets a little fluid, right? I don't know if that's a word, a little fluid. So it starts spilling out a little bit of fluid, okay? But then, it starts crusting over, all right? After that pustule ruptures and it ulcerates, can everybody see the mouse on the screen?
Sir.
Yes? All right. See this little red area that's all around this ulceration here? Okay. See it all around here? Okay, this is what we call a brawny area. Okay. So if you look at this area, it says outer ring of non-tender brawny edema. That's what that is. Okay. If you go to push on that, that's hard. Okay. Doesn't hurt, but it's just hard, especially compared to the skin next to it when you push on it. After it starts drying up, after it ulcerates, you'll get that black scab, right? And you can see that in that second picture down on the right. Okay, that's a really hallmark sign, black scar is what we call it, of a healing anthrax wound. This can take weeks to months to heal and go away, depending on how big it is, and, or how deep it was. Okay, 25% mortality rate if untreated. Why? Because they're going to become systemic and goes everywhere else in the body. All right. Okay, this gentleman here has some cutaneous anthrax here on his face. This young lady here has a healing black scar here over her left eye. Alright, the inhalation anthrax, two different phases, or two different stages, okay? You have your initial, and you have your pneumonic. Here's part of the problem with anthrax. Look at all the symptoms that it has in the initial phase. Viral upper respiratory symptoms, flu-like, fever, malaise, muscle aches, visual lymphadenopathy, rhinorrhea, pharyngitis. What does that sound like to you if somebody just shows up like that? That sounds like the flu, right? Kind of sounds like the flu, right? And generally, we're trained to like, all right, the most common stuff, all right, it's flu. Okay, here's some Tylenol, go home, rest, drink plenty of fluids, all right? You do your ER precautions. If you're having difficulties breathing, please come back. Not to me, but to the emergency room, right? But by the time they come back, they're already in the pneumonic phase. And if you look at the pneumonic phase, they already have fever, dyspnea, okay, chest pain, bluish discoloration of the skin, hemoptysis. Okay. Why? It's a really good question that we always ask is why, right? So a lot of times what happens is when anthrax gets into your system, it attacks your macrophages. Right? The macrophages go in and try to protect you. Right? That's what white blood cells do. What happens is this thing hijacks your white blood cells. Hijacks your white blood cells, particularly in your lungs, right? Because we're talking inhalation. White blood cell home base is what? The lymph nodes, right? So all the lymph nodes, generally in your chest, are along your mediastinum, right? guys remember your anatomy? Mediastinum, sternum, right? So once those macrophages get invaded by the anthrax, the white blood cells go back to their home base, the lymph tissue, right alongside of your sternum or your mediastinum, and then they start causing havoc. They release a bunch of toxins. The toxins start breaking down your tissue. As your tissue breaks down, it causes leakage and vascular leakage, which starts causing fluid to start accumulating in the lungs. Hence why you end up with the bluish discoloration of the skin and hemoptysis, chest pain, difficulty breathing, right? Because your lungs are filling up with fluid. All right? So that's generally what's happening here. And if you look at that mortality rate, 80 to 100%. 80 to 100%. If you don't catch it early. And the key point here is that early looks like the flu. Okay? So you kind of got to be astute about some of this stuff. All right? For real world things. And the timing is usually 1 to 7 days after exposure, but it can take up to 2 weeks. But you'll start having some of those initial corrosion issues. So the next one is intestinal anthrax. That means you probably ate something that was contaminated, right? So it's going to look like AGE, acute gastroenteritis, nausea, vomiting, diarrhea, fever, cramps, dehydration, right? The whole gambit. What do we generally do for acute gastroenteritis? I know you guys haven't had GI yet, but usually, if it's less than 72 hours, book answer is usually 48, usually for us, at least for me, usually about 72 hours. Right? I'm not going to give them anything to stop it, right? Because your body's trying to get rid of it. If your body's trying to get rid of it, why am I going to give them something to stop it, right? So, depending upon how much is going out, is what you have to kind of sort of gauge. Right? They may have some hematemesis, right? Maybe throwing up some blood. So severe diarrhea, bloody. So as we go through this, bloody diarrhea versus non-bloody diarrhea is a way to start kind of sort of differentiating some of the disease processes that we're going to cover. So for this one, it's going to be bloody. Why? Because the same lethal and I can't remember the other toxin. I think it's a demon toxin. Lethal toxin and demon toxin, they destroy the inner lining of your intestinal tract. And they cause inflammatory problems in your intestinal tract, which go ahead and starts allowing blood to leak in, it starts allowing inflammation and destruction and vascular leakage into your intestinal tract, causing all this stuff. Right? So, a way to remember some of these different diseases that we'll cover will be bloody versus non-bloody diarrhea. Okay? In this case, it's bloody. You can have an acute abdomen, sepsis, and occasionally massive ascites. That ascites is because of the vascular leakage. It's getting into your abdominal cavity. Okay? And they'll ask you, hey, is this an abdominal belly? Do we need to do surgery? That's what you'll have to figure out, yes or no, during your surgical rotation. Right, major mortality rate, 25 to 60%. Okay, so here's some labs that we're going to do. So I'll tell you right now, PCR is the answer. And if you have a choice for most, keyword here is most, disease processes when you're going to ask for a lab, the answer is PCR. Why? Because PCR is very specific for DNA. It's specific and sensitive. Okay? The problem with that is every single disease process doesn't have a PCR test, so you have to figure out which ones do and which ones don't. PCR is expensive. And most of the places where this stuff occurs does not have PCR. So you need to know the other things to do, okay? I get two big questions from students nowadays as to why I put all these labs on here. I put the labs on here because, number one, all these labs aren't available at every place you go. So you have to figure out what other lab you can do to figure out what the disease process is, okay? Especially when you're working overseas, okay? Another question I get is, why do I put more than one drug on some of these disease processes? Is because sometimes that first drug may or may not be available, so you need to have backups. Right? And the example I used when I was working in the civilian sector, where they said, hey, this drug, insurance doesn't cover it, you need to pick another one. Well, if you didn't understand or know what other family or class of medications will take care of that, you're gonna have to start flipping through books while you're on the phone with the pharmacist to figure out what else you can get. At this point here, you're getting more than one, all right? And a lot of times they're in different class or different family of medications, all right? So, moving forward, a lot of times, I'm not gonna necessarily just give you a PCR lab on your test, okay? So, you may need to know some of these other ones. But if at all possible, and you do have the opportunity to do PCR, PCR is the way to go, all right? Highly sensitive, highly specific. The other nice thing about PCR, for the most part, is that it can detect things early. So the next one you have here is rapid ELISA. The problem with ELISA or IFA are that if you don't have enough antigens in your body at the very beginning, they'll come back negative. Okay? Because your body has not developed enough for it to get picked up, which means you'll have to do it a little bit later again. Because the first one may be a false positive or a false negative. False negative. Okay? So those are things you'll have to be careful with the rapid ELISA test. Nasal swabs, we generally do not do unless we're continuous an outbreak. Right? I don't need to do every single body in here with a nasal swab. Big things with nasal swabs are that if you come back negative, you may not be negative. If you come back positive, you're positive. But if you come back negative, you may not be negative. Part of the problem with nasal swabs. Okay. So generally we don't do nasal swabbing unless we're doing like epidemic type stuff. Okay. If you do a gram stain, right? If you do a gram stain, this is what the gram stain is going to look like. All right, it will be a gram-positive, non-motile, facultative anaerobe, but we'll have these little oval endospores inside these little rectangle things. Okay, see some of these didn't get fully stained. Like here's the other little ovals that didn't get fully stained, but this is generally what they look like. All right. I generally do not ask you all this crazy stuff like micro does with the staining and all that, because this is not micro. Blood cultures are usually 6 to 24 hours. It'll eventually come back. If you're thinking inhalation, right, you'll want to do sputum cultures, right? If you think it is neurologic, then you'll do CSF or a lumbar puncture so that you can send that off to the lab. All right. If it's cutaneous, hey, swab one of those blisters that they have on their hands or arms, send that off to the lab. And if it's intestinal, any vomit or any feces that comes out is what you need to send off to the lab. Okay? All right. Chest x-ray. If you look at what the chest x-ray is going to look like for inhalation anthrax, it's going to look like a widened mediastinum. Okay? And we covered that before. right? All that stuff is going back to the lymph node tissue that sits right along the sternum. As they get inflamed and start leaking, they swell up. So as you take that chest x-ray, you're gonna have that widening mediastinum. Yes, sir.
Would you say that generally happens like relatively early or late in the process?
For inhalation or
Yeah.
for the
For-
widening of the mediastinum?
Yes.
So this usually happens pretty quick. Right? It can happen anywhere between 2 to 7 days, depending upon how much. So there's a lot of depends with infectious disease, right? One of the depends is how many spores that you actually inhale, right? Obviously, the more spores you inhale, the faster it's gonna happen, okay? The less spores, the slower it'll happen, because it takes some time to germinate and grow, right? Versus, if I'm an incompetent person, right, or I'm a neutropenic person, it may happen pretty quick, right? Because I have no defenses, I have no body defenses to help me, right? So I'll start having breathing problems tomorrow, right? Now, if you're a healthy, competent person like yourself, your body defenses will try to attack it, right? And it'll put up a good fight till it can't fight no more, or till it makes it to the lymph node tissue. And on average, usually 2 to 7 days is usually what we look at for it to start happening. And in the respiratory system usually happens a lot quicker than in the intestinal tract or the cutaneous system. Answer your question?
Yes, sir.
Okay. Anybody else? So another name for this is hemorrhagic mediastinitis. Right? As we mentioned, that vascular leakage is what causes it to give them that name. Okay. Pretty easy. Right? If you have cutaneous anthrax, you're gonna get 7 to 10 days worth of pick one, Cipro or Doxy. Okay. Any questions with that? No? All right. So generally, I am not gonna also ask you milligrams, and I'm not gonna ask you generally how long, right? If I know you know the right medication to use, then in all reality, we can pull it up, right? Because when we're working for real, we have our book, we have our iPad, we have our eyes. Right? So from my standpoint, I usually am not gonna ask you the milligrams, usually, all right? This is where it gets a little bit trickier. I tried to write this out so it makes a little bit more sense for you. All right. Now, caveat for all infectious disease, supportive care. Number one is gonna be supportive care. Number one will be supportive care for all infectious disease stuff. All of my slides don't necessarily have supportive care on them, but I'm letting you know right now. Number one is supportive care. If the person can't breathe, it doesn't matter that you give them an antibiotic, okay? I don't care, there's not an argument here, okay? If the person's not alive, then I don't care what you gave, even if you gave them the right stuff, okay? Now, let's understand, supportive care isn't just oxygen, okay? Fever control. If his brain is frying, it's probably not getting better, right? Obviously, oxygen. Mechanical ventilation is needed, right? This guy is gonna be in the hospital because he's got fluid in his lungs. How do you take fluid out of the lungs?
Big
Chest
needle.
tube, right? You don't have to have a chest tube. You gonna send somebody home with a chest tube? Probably not, probably take an ICU or something like that, maybe on the floor. But mechanical ventilation would be another thing, chest tube. Okay. IV fluids, dehydrating, right? Vasopressors because his blood pressure is super low or super high. Okay. All these things fall under supportive care. All right, so we wanna make sure that we try to stabilize that guy as best we can. As we all right, so that's your supportive care. Okay, so he's gonna require 3 antibiotics. And this is where it gets a little bit tricky. Okay, they're gonna be IV antibiotics for 2 weeks or until the person is clinically stable. What does that mean? That means that he's not getting any worse and his vital signs are pretty much the same. Okay? He's not tanking. All right, that's what clinically stable means. Not that he's getting better or all better, but that his vital signs have been pretty much the same and they're not getting any worse. All right? Then you have two things. Okay? You have two choices. You have Rixbacumab or anthrax immunoglobulin. Rixbacumab is a monoclonal antibody. What that means is that they made that in a lab. Okay? What that does is it blocks the anthrax from continuing to do more damage and getting into your cells. That's what it does. Okay? The anthrax immunoglobulin kind of sort of does the same thing in a different manner, but it is human derived. Okay, big difference, right? So one we made in the lab, it's artificial. One is human derived, okay? So it is. LT Brandy. All right. So LT Brandy survived anthrax, inhalation anthrax, and I took antibodies from Lieutenant Brandy, and that's how I made my anthrax immunoglobulin. Okay. How much do you think I can get from her to be able to keep giving patients to help them with their inhalation anthrax problem?
Couple?
It's a little bit, right? I can't take a whole bunch, right? I want to drain her dry, right? So we only have a small portion of anthrax immunoglobulin, okay? Versus Rixbacumab, where I can make as much as I want in the lab with no issues, no problems, right? So big difference. So it'll be your choice as to which one you want to use, and it's dependent upon where you are and what's available. All right? Big deal? Rax, 1 injection. I think it's 40 kilograms per milliliter or something to that effect. 1 shot. That's it. That's all you need. Versus AIG, I have to keep giving that to the patient as the patient starts tanking again, because it goes away a lot faster than Rax does. So there's some pluses and minuses there, right? Anytime we talk about human-derived blood product, we have to worry about what kind of effect is it going to have on me, because her blood type is not my blood type, right? So that RH factor may jack up and may make those side effects worse for me, but when I gave it to O.C. Wright, it was good. No issues, no problem. So we have to kind of be careful with those human-derived products as well. Okay? After that, once the patient is stable, right, you're going to pick a single oral antibiotic and you're going to give it to them for 60 days. All right? That is very specific to kill any spores left inside the body. That is why you're getting 60 days of this other medication after the fact. And then concurrently at the same time, once you start the oral medication, you will also vaccinate with a short course of day 0, 2 weeks, and then 4 weeks later. Okay. What does that look like? That looks like this. Okay. Always supportive care. Okay. The 3 antibiotics that you're going to use will be Cipro, meropenem, and minocycline. There are a whole bunch of different versions of this. There's about 10 different versions of treatment for this. And we can substitute any of these medications with a whole bunch of different things. All right? This is the one that we're going to go with. I like the meropenem specifically because it's broad-based and it'll cover a lot of different things. So this is the one that we're going to go with. All right? If it is penicillin sensitive, we can also substitute penicillin. All right? So again, there's a whole bunch of different ways to do this, but this is the method that we're gonna go. All right? Once you have that stability of the 3 medications after those 2 weeks, then you're gonna pick one of the 2, Rax or AIG. And then you're gonna do 60 days worth of Cipro or Doxy, one or the other. And then at the same time you start that, you'll give the anthrax vaccine. Anybody have any questions on the treatment for this? It's gonna become a little bit more complicated, but it's all there. No? This one basically tells you Raxalmid is a monoclonal antibody, and anthrax immunoglobulin is a blood product. Anthrax vaccine absorbed AVA, that's the vaccine that we use, the anthrax vaccine. There it tells you it is an initial series of 6 doses, 18 months, 0, 4 weeks, 6 months, 12 months later, 18 months later, and 30 months later. Usually it's a once-a-year booster. And then post-exposure prophylaxis, which is what we have at the very end of the treatment, will be on day 0, 2 weeks later, and then 4 weeks after that, along with that 60-day course of antibiotics. All right, and that one is very specific for causing your body to develop antibodies against it for the future, and the 60 days worth of antibiotics to get rid of any spores left over in the intestinal system or in the lungs. You will see this on a lot of my slides. I give you some differentials. Differentials are not on your exam. Differentials are not on your exam. But I give these to you so you get a little bit smarter. When you start doing junior clin core, at a minimum, there's gonna be 2 differential diagnoses required for whatever your scenario is gonna be in junior clin core and in senior clin core. So I just give you these just so you can get a little bit smarter or have something off the top of your head for respiratory or cutaneous issues. Okay? These are not on the exam. Alright, next thing we're gonna talk about is the plague. Do you guys know much about the plague? No? A little bit? How much? Rat? Rat's not bad? Is that rat?
It's in Idaho.
So this world has had 3 large plague epidemics. 3. According to the CDC, one of these epidemics, their guesstimation of the world population was about 500 million people. Right? During this one of the 3 epidemics. Their guesstimation of how many people died was about 200 million people. That's almost 50% of the population died because of this. Okay. Do we still have outbreaks of this? Do we have this in the United States? Yes, yes we do. All right. This is where it becomes important to know or understand, depending upon where you work, is what's going to be most prominent. What does that mean? Okay, what that means is, if I know I'm in the Southwest United States, I know that this is a prevalent thing that could possibly happen. Okay? Versus, if I'm in the Northeast United States, I know that Lyme's disease has a much higher propensity than the plague in the Northeast United States. Okay? So depending upon where in the US or the world you work is what's going to be more common in those areas. So one of those things that you should do when you get to wherever you're going is ask those folks, hey, what's more common in this area? Okay? And or if you remember some of these things, you might already know. Okay? So here the offending organism is Yersinia pestis. All right? So remember those big words. Okay? How does this usually happen? It's usually a flea bite. a flea will bite an infected rat or something to that effect, or it'll live on the rat and the rat scurries everywhere. And then it jumps on you, and then it bites you, and then you get it from the flea. Alright? Now, contact with infected animals, human to human, or contaminated materials can also spread it. Alright? So the original thought process was, as the distribution chain came from the west to the east, right, from China to Europe, rats jumped on all those cargo trains, and you saw it spreading from the west to the east. As you look at all the modeled maps of the plague, going all the way to the east. They jumped on cargo ships and made it all the way up to the United Kingdom, across the water. They weren't quite sure if they were gonna get it, but they got it. Right? This is what we do consider a zoonotic disease. Mice, rats, rabbits, squirrels, chipmunks, prairie dogs, they can all be infected. But generally the flea, once they bite them, is what generally spreads it to us. Okay? Look, worldwide distribution. But if you look at the next one, mostly in the southwest United States, New Mexico, Arizona, Colorado, California. So if you're working in these states, okay, it's more prevalent there than it is anywhere else in the U.S. Big thing with this one, it only gives you temporary immunity. So if you get it, it may protect you a little bit, but then you can still get it again. All right. Now, they have done studies both for this and HIV, and the reason I compare both of these are because there is a gene called D32. If you have gene D32, it may protect you from the plague, and it also may protect you from getting HIV. This is new stuff that's been coming out as of the last 4 years. So we're getting newer and newer stuff every day. Right now we're gonna have to be careful because the CDC is in turmoil. So you may not be getting any good information from the CDC anytime soon. FYI. Fleas usually cause the bubonic plague, and then if it does become pneumonic, right, it does get to your lungs, that's when it's really, really bad, all right? Because generally it's the flea that has to bite you, right? Once it gets into your lungs, you cough and spit and laugh and yell and scream, you can spread it to somebody else, okay? So if you read any of the little pre-read literature, I gave you a bunch of ESL levels 1, 2, 3, and 4, right? This would be one of those biosafety labs, number 3, okay? Especially when it becomes pneumonic. All right? That is not testable, but just an FYI, because when you send certain things to the lab, when you tell them what you're looking for, is what they'll do. If you tell them you're looking for the plague, they're not gonna do it at the Moreno Clinic lab. Moreno Clinic lab is gonna be like, what? They will probably call you, and then they will probably call the CDC, because the CDC has bio-level 3 for their lab capability. Moreno Clinic does not. Okay. All right, 3 types that we're really gonna talk about: bubonic plague, septicemic plague, and pneumonic plague. Keyword, highlight, buboes for bubonic plague. Okay, if you see bubo, likelihood it's probably the plague. Okay, bubonic type. What does that mean? That means that you have some of that infection caught up by your lymph nodes, and the lymph nodes have swollen up, become enlarged red tint. And we'll talk about that here. Okay, septicemic plague, aka Black Death. Right? There's 2 reasons why they call this stuff the Black Death. Pustules and papules that you get is you're gonna turn black, 1. And 2, this stuff causes vasculitis with BIC, Simmons, with vascular coagulopathy, right? It breaks down a lot of fiber products inside your blood, causes a lot of coagulation. What are the smallest vessels in your body?
Periphery veins.
What are they? No? Not it? Okay. fingers, toes, penis, nose, earlobes, and the back of the eyes. Okay? Smallest vessels in the body. So when you look at these bodies that have the plague, right? You look at their fingers, their fingertips are all black. You look at the tips of their noses, they're black. You look at their toes and their feet, they're black because of the vasculitis, because of the coagulopathy. All right? So, main reason why they call it the Black Death. Two different reasons, but that's one of the big things that you'll generally see on when you're looking at some of these after pictures of these bodies. Especially when you look at the medieval pictures of the time, you'll see a lot of them drawn with the black fingers, black nose, black earlobes, all right, because of that. And then you have the pneumonic plague, which usually that is what happens ultimately as this continues to process through your body. Okay, it'll eventually become into your blood or eventually make it up to your lungs, and then you end up with a pneumonic plague. All right. These are not going to be on your test, but these are cases that have occurred here in the U.S. Last month was the first case that they had over in Colorado, which was nationally televised. Okay, but if you look here in 2024, Southern Colorado is a hotspot for plague in the U.S., and it's mostly occurs sporadically in rural areas. Okay? So, for the U.S., in most cases, it'll be a rural area within some of those U.S. states that we mentioned earlier. All right, New Mexico, Colorado, California. So it won't necessarily be in the larger cities like it used to be back in the day. Back in the day, when we talk about the 3 times that the plague actually affected the world, a lot of it occurred within the big cities because there was trash everywhere, hygiene was unkept, people were sleeping on top of each other, there was no space to move around, so they came into a lot of contact with each other, so bigger cities were having serious problems. Nowadays, it's the complete opposite. It's more rural areas that are having the plague issues. Okay? So here's a bunch of plague cases that are happening here in the U.S. Okay? This is what the CDC map looks like, which is where they came up with, hey, these are the most common states that the plague is found. Right, one of the last urban outbreaks that we had, which were rat associated, occurred in Los Angeles back in 1924. So that was quite a long time ago, right? So since then we've gotten much, much better. Okay. Worldwide, when you look at it, all right, it looks like in a lot of different parts of the world. Right? Russia, Mongolia, China. Okay. Anybody know what this is?
Madagascar.
Yeah. That's probably the worst place in the world for plague. Okay, at least according to the stats. Alright. Alright, so let's talk about some signs and symptoms. Actually, you know what, let's go ahead and stop here and we'll start